Greetings, I'm Frank Cetta. I'm the chair of the Division of Pediatric Cardiology at the Mayo Clinic. And on Medscape this morning, we're bringing you an interesting topic related to going back to school. Summer's in full swing, and children are going back to school, and topics come up or questions come up about what kind of screening they need before participating in sports. And joining me today is my colleague in pediatric cardiology, Dr. Michael Ackerman, who is a world-renowned expert in the assessment of children and young adults for possibilities of sudden death. He's the head of the Sudden Death and Genomics program here at Mayo. Welcome, Mike.
Thanks a lot, Frank. Great
Mike,
to be here.
This is an area of great controversy in the United States. There have been programs in Europe that are fairly well established for screening children prior to attending school. What do you think about where we're at here in the United States currently with these programs? We see it on an ad hoc basis in some communities where there's ECG screening or echo screening, but maybe we should just start from the beginning. What's probably the most important thing to start with these programs?
Yeah, I think the issue is, of course we should be doing it, but then we look under the hood and say, well, wait a second, and I think that's the dilemma.
Yeah.
So we talk about sudden death screening, and we make it sound as if we're screening for an entity called a heart disease that causes sudden death.
Right.
But what we're really doing is we're talking about a dozen, 24 different discrete heart conditions that can culminate in sudden death, for which the same screening strategy may not work.
Right.
And yes, the Italians do it. They're probably the best example, and so let's just be like Italy.
Yeah.
But it's not so simple and straightforward as that. I think there's a lot of issues that one has to really dissect if we're going to do it right. And I'm not sure that we're there yet. You say, of course we should, because these conditions cause sudden death. Sudden death is an awful thing to happen. We would sure like to prevent that. And for the most part, most of the conditions that we're talking about screening for, they are highly treatable conditions.
Right.
So in that sense, of course we should. It affects 1 in 80,000 people, 1 in 100,000 kids will die suddenly each year. And thankfully that's rare, but the calls come out to say, should we be screening for those conditions? We must be screening for those conditions. Why are we not doing what Italy does? And I think you and I have talked about some of the why nots.
Right, right. I think it's an emotionally highly charged issue. When we have a young athlete go down suddenly on the soccer field or the football field during summer practice or two-a-days for football, the local media is all over it. It's highly charged, obviously, for the families. This is an incredibly tragic event when it happens. What do you think is the most important aspect of this? We spend a lot of time is spent with, well, should you have an ECG, should an echo, should you have a treadmill, should you have all three or two of the three? Where should we start with this? What are the basics?
Yeah, I think if a screening program, when we talk in general about a screening program, really to have one work, it starts with the 12-lead ECG. But even that is insufficient for some of the conditions, like a coronary artery anomaly will never be detected by an ECG. The ECG, when? Yeah. Do we do it right out of the gate for newborns? Well, that would be a great idea for one of the conditions, long QT syndrome. It would be a terrible idea for hypertrophic cardiomyopathy. Yeah. And so even the ECG, which is kind of what's been rolled out as various communities, that has stumbling blocks. And I think one of the things that concerns me about the ECG screening programs is there's very little guidance, a little bit of the Wild West going on. What do you flag? When do you flag it? How long of a QT interval? What about the T waves? What about a Q wave? When? And I think we're just now starting to have some guidance with things like the Seattle criteria, which we've just now generated a second version, to give some guidance as to if we're going to do a screening program, these are sort of the fouls, the penalty flags that we'll toss, and there's been a greater sensitivity to now the dark side of the screening, which is the false positives.
Right, right.
What we see here at Mayo, right, are the false positives.
Exactly.
And nobody really talks about that, and I think it's pretty sobering when you pause and think about the cost and the energy to remove a diagnosis when the penalty flag has been tossed because of a screening ECG finding.
Sure.
And nobody talks about how difficult it is to pick up the flag.
Right, right.
And
No, I agree. I think also, even before we get to any type of testing, probably at the level of the primary care physician, awareness in the families with the parents and the adolescents about what their family history is,
Yeah,
I think is key. I think that's the best starting point. And any of these screening programs, ones that we've participated in here or ones that we've been involved with vicariously, family history, knowing the family history, that seems to be actually a fairly good way to catch some of these things ahead of time.
Yeah.
I agree with you completely. With ECG, we don't really know how many adolescents have been screened and labeled as normal, yet they go on maybe and have an event. We don't have data on that. We have more and more data about the false positives,
right.
who sometimes maybe even have had previous abnormal ECGs or heart surgery, yet they come up with a...
You know, the point you made about the family history I think is really huge. We and others have published showing that about half of all of the sudden deaths that occur in young people, that there was a legitimate warning sign before the sudden death.
Yeah.
And that warning sign has usually been one of two things. Either a personal warning, I fainted suddenly during exercise, or I had sudden exertional chest pain, so they had their own warning sign, or a legitimate warning sign in the family tree, the family structure of unexplained sudden death. So if we acted on the warning signs, we could, in theory, decrease half of the sudden deaths.
Right.
Now the other half, where the death is truly the sentinel event, that we only have two options really. We either screen for those, or we have a post-event reaction.
Yeah.
And so if screening, we talked about screening a little bit, but the post-sudden death reaction plan of having us, the physician community, be more active in getting an expectation. Wouldn't it be great if every high school kid needed to do CPR as a high school graduation requirement?
Sure.
And we get AEDs in the public square. So for that athlete, and for that matter, the artist, that's who goes down, whoever goes down, whatever their tagline is, there's a chance to revive them in a successful way.
True. True. No, I think public access to AEDs has probably made a big impact on this whole area. As we close, I think one comment maybe about echo. We see more and more echo screening occurring because we have these small portable machines. There are some now that are the size of my cell phone, essentially. There are limits to it, and I think many of us in the echo community have always felt if these echoes took 5 minutes to do, cost $5, and were very reproducible from operator to operator, it would be a great way to have universal screening, but we know we're not at any of those criteria yet. Obviously, echo can help screen for cardiomyopathies. I think on the quick fly, looking for coronary anomalies is much more variable and needs much more experienced people doing that. So there are limits to echo screening, but certainly we know there are a lot of programs around the country that involve good history taking, an ECG, and a limited echo, and those seem to be propagating more in the school systems. Let's see. I think we're in the let's try to start gathering some data on these things.
But I think the last point I would make also is I think the way forward is we need to stop talking about pre-sport screening for sudden death and start talking about the individual diseases that cause sudden death and start asking the question, is that disease worth screening? Are we there yet? Do we have it right yet? Because when we lump it all together, I think we're missing the point of that it's not the same strategy for screening for long QT syndrome, which I do think we're at a point to be advocating for universal screening. That's the other point, is universal. I've always been bothered by this. Let's find a sudden death predisposing condition in an athlete, but let's forget about it in the artist or the chess player or the band member. I think if these conditions are worthy of screening, they're worthy of screening in all children, not just those who happen to be on the basketball court.
Well, that's a great point. So thanks, Mike. I think these great insights, great conversation. We'd like to thank those viewers. You can tune into Mayo Clinic at theheart.org on Medscape to review this. Thank you.